get your feedback on the emergency care algorithms 2021. Maybe just to kick off, so today's presentation, again, welcome everyone. Today's presentation is looking at the 2021 updates for the emergency care algorithms. We specifically chose to do this at this particular point because we realized it's been 5 years since we first released the first set of algorithms in 2015. And at that point, it was a small spiral bound book, now has grown over the years. And I don't know, maybe before we even just discuss what's in the updates and all, maybe we can get some feedback from people. Who's using the algorithms? How are they using the algorithms? What value do they find in the algorithms? Or what limitations do they find in the algorithms? Again, feel free to unmute yourself and just speak. Anyone? Are we using the algorithms? Are we not using the algorithms? What are we using the algorithms for? How useful are they? Yes. Should we stop making them? Any comments from anyone?
Hi, Prof.
Yes.
Yes, personally, I do use the algorithms once in a while. Even the other day, I was able to just reform the algorithm on the management of the status epilepticus. And it is really helpful also.
Okay, they're helpful. All right. Anyone else? Thanks, Johnson. Again, feel free to just unmute yourself and mic. Yes, Dennis.
Hello, I'm Kenywa.
Yes.
Clinical officer specializing in emergency medicine.
Yes.
And I refer to the logarithms. Like yesterday, I had a case on poisoning.
Okay.
And I really benefited from the logarithms on poisoning. Although I found a challenge where some of my colleagues were saying we need to lavage an OPP patient.
Yes.
And I'm there with my logarithm showing them that you should not lavage. And we really had a long discussion.
Yes.
And we ended up actually lavaging, but I kept on insisting that we shouldn't. So I don't know. I really have, I don't know what to call it, but maybe we need to have references at the back of the algorithms where some of this data comes from, so that when you are sharing these algorithms with colleagues, because emergency care is a team effort.
Yes.
So that you are able to at least change those, maybe someone learned that in school, so convincing them from one reference book might not be adequate. So that has been my experience so far with the algorithms. Otherwise, they are good, very easy to reference, and they provide immediate actionable information that you can follow on a real-time basis as you manage various emergencies. Thank you.
Thank you very much, Dennis. Maybe agree. I mean, it's something very common, even in many situations. Trying to convince people what's in the algorithms is the right thing versus what is they're used to practice. How many people have also experienced such challenges? Again, feel free to just unmute and mic. Mute your mic and speak. When the algorithms say one thing, but you've been practicing something else, and trying to convince people that you need to follow the algorithms is a challenge. Anyone else having the same challenges Dennis is having? People, it's an open mic session. So the more we talk, the more we engage, the more we learn from each other. This is not supposed to be a PowerPoint presentation. Otherwise, it would be very boring. Anyone else having challenges implementing the protocols, the algorithms? Okay, but just to address some of Dennis's comments, at the end of the book, we've provided some specific references. Agreeably, we have over 40 algorithms, so we may need to increase references for every single component, but everything in the algorithm is evidence-based. We do skim through as many resources as possible, and that's why we have to keep them updated annually to make sure that we are providing the latest evidence and not outdated. And that's why you must always change. So if your algorithm does not read the current year, then you're probably looking at old evidence. So because and that's the thing about evidence-based medicine and evidence-based care is there's such rapid changes in medicine that if you do not keep up, then you risk practicing outdated medicine. And I know a good example that has brought a lot of discussions is even just the COVID pandemic at the moment. At the beginning, hydroxychloroquine was being used, then the evidence changed, it's no longer being used, then there was another drug being used, then it was not being used, then dexamethasone came in, and now that's what's being used. So with the changes in evidence and changes of practice, we need to, as healthcare workers, especially working in the front line, we need to be able to keep up to date with the current practices. Otherwise, we risk potentially harming the patient or providing care that is outdated. And just on a specific discussion about gastric lavage, that is definitely outdated. Even in veterinary practice, it's outdated. And there's a lot of good evidence behind that. So today's talk is not necessarily to go specifically page by page looking at each and every evidence. What we'll do is we'll probably just give you an update of some of the things we've updated in the 2021 algorithm. So focusing a lot on the advances in science from last year, 2020, and then moving up what then was updated. But all the other parts of the algorithm are still evidence-based and may not necessarily have changed much since the last update. So in terms of why we make the algorithms and why we choose to specifically use the algorithms is essentially trying to make sure that everyone is practicing evidence-based care. The management, just to use the example of organophosphate poisoning, management of organophosphate poisoning in Aga Khan University Hospital Emergency Department should not be different from the management of organophosphate poisoning in Kihara Sub-County Hospital. We should all be reading from the same science, and where there's a variation of science, then that means someone is not up to date or we are not reading the appropriate resources. And what a lot of research has shown, of course, is that standardizing care then allows you to get the same outcomes as per what the evidence shows. So if you do not practice evidence-based medicine, then you will always have variable outcomes in your patients. And that's the idea behind making sure that we actually having standardized care. And that has been our objective. And that's why every year we produce these algorithms and we share them across the country. So it's freely downloadable, but you also send print copies to all emergency departments in the public hospitals so that everyone has a reference point. I do not want to be suffering organophosphate in Kisumu and I'm being treated differently from if I was in Mombasa or and that should not be the case if we are all practicing science. We're all reading the same. And yes, medicine did change significantly since I graduated from medical school and similarly to everyone else. So it's up to us to keep up to date. So they also help us, the algorithms also help us conserve resources by standardizing care orders and resource use, meaning you save your patient money. And this a lot, again, focusing mainly where private healthcare people order tests left, right, and center and treatments left, right, and center that do not necessarily have any evidence. And what we've tried to do is make sure that whatever is recommended is as evidence-based as possible and also with cognizant of what is the best. I mean, there are many ways. For example, if you're saying, well, you want to diagnose pancreatitis, then a lipase is more specific and you're more specific than an amylase. So there's no use of ordering an amylase and a lipase just to diagnose pancreatitis. So you just need the one of them. Similarly, looking at different treatment options, different tests. I don't think you'll find anywhere on those algorithms you'll find a CRP, which is of no value for us in the emergency department. And as much as possible, the treatment recommendations and the investigations are all based on what is the best practice, evidence-based practice, but also bare minimum you have to do for the patient to make sure that the patient gets the best outcome. Of course, they also reduce confusion a lot, and if you're all reading from the same script, then everyone should be able to know what needs to be done without people having to guess. So the doctor and the nurse should be able to read from the same algorithm and provide combined care or unified form of care. And this is, again, looking at the teamwork that we promote in the emergency department. You cannot, someone was mentioning about status epilepticus, the nurse should be able to predict what the next drug will be given because she's also reading the same algorithm. I know there is a lot of CADA fights that happen in many places, but I think the emergency department is one place where there's teamwork and less about the CADA. So the nurses need to also know what to expect the doctor to do, and similarly, the doctor should be able to work concurrently with the nurses and the clinical officers, and all of you should be on the same page. This helps a lot, especially where sometimes you have new staff who come in, and a lot of times it's new staff who are straight from training, who may not have the experience to manage some of the emergencies. And if your nursing team, which rarely changes, if your nursing team is up to speed, then they should be able to also orientate the new doctor. So it provides that reference point that supports people during an emergency. The other thing, of course, it reduces errors, again, for the same reasons. All patients receive the same management and potential errors are more easily recognized. Promote team building because the protocol components involve several different services within the hospital and within the department. And of course, teach a consistent, workable approach, especially important when, as I said, trainees or people who are recently graduated, then they are familiar with a single evidence-based approach that will work for them in their practice. Anyone else who can say any benefits you found from using the protocols beyond what I have said, or any other benefits you see, why it is important that we use protocols? And I think one of the things I'd say is the role of protocols across healthcare is one of the things that has been pushed for many years, and in emergency care services we use them a lot compared to other services, and it's not necessarily that you don't know what you're doing, but it's always good to have a reference point to make sure that you know exactly what needs to be done. And even if you look at it, even pilots have checklists when they are flying the plane. It's not that they've never flown the plane before. I mean, at the beginning of every flight, they have to go through a checklist, even with 50 years plus of experience. And this is, again, to make sure that nothing is being missed. The plane is flying smoothly, not the patient inside. But, and similarly, even when we are providing our emergency care, we should be very happy to use checklists and protocols to, at best, standardize the care that we provide. Anyone with any comment in terms of the use of protocols, the benefits they've seen, or what, just any comment on that, on what we've been discussing so far. Remember, these are open mic sessions. You can unmute yourself and speak.
Hi, Dr. Washira.
Hi, Tej. How are you?
I'm well, thank you. Yeah, Doc, I just wanted to give my experience with these protocols. I mean, in working life, in clinical practice, it really helps with confidence, especially as you were saying, when you're maybe a more junior member in a team, or you've just joined a new work environment. I found it personally to be extremely useful. Of late, I've been involved in medical education a lot more, especially with younger medical students. And the sooner they get introduced to these kinds of things, I found that their ability to learn from these experiences in their clinical rotations is far, far better. I get so much feedback from people thanking me for introducing them to these protocols, just because they are able to now go into the wards or go and shadow doctors in the emergency departments and actually learn way more after being oriented in how these emergencies are dealt with.
Yeah. Yeah, thanks, Tej. And yes, again, that's another important part. We've always sent these protocols to the graduating medical students at the end of the year when they're graduating. And again, it's because of that. It's an educational tool, especially for people who are just joining into practice. Remember, especially interns. Interns are normally the first people to handle emergencies in most of the facilities because they're the ones on the ground. And the same feedback has been that, yes, they do find the protocols useful to just help them. And the other thing, which again is something that always amazed me about how we practice medicine, is the consultants always had information that the junior team members never had. So the junior team members would do something, would do their best, and then the consultant would come and say, "Oh, why didn't you do this?" But the junior person, of course, did not have that information the consultant has. But what I found with the algorithms, and that's why I still promote them, is it's this, we all should be knowing the same information, the consultant, the junior doctor, because at the end of the day, we're there for the benefit of the patient, and we want the best outcomes for our patients, and not necessarily just to show who knows more than the other. It's the best outcomes is our main objective. All right, good. Thanks, Tej. Anyone else with a comment?
Morning, Prof.
Morning. But then you can
My
call
name
me
is.
Benjamin, eh? This prof business. Yes, all of you.
Okay, sure.
Yeah. Yes.
Okay, sure. My name is Lucy.
Yes, Lucy.
And I teach nursing students, the undergraduates and postgraduates.
Yes.
And basically, I've been, for the last, I think, 2 years, I've been utilizing the protocols.
Yes.
And also trying to basically gauge, how can I put it? Basically, I've been using the protocols together with the AHA guidelines in regards to the BLS and ACLS protocols.
Yes.
And it's been really helpful because, again, I can talk from an angle of now we have something that is localized as from our setup. So yes. the protocols, going by your last pointer on why, basically it's really helping, especially for my nursing students. Yes. When they go out there, they are able to actually be able to know what is expected of them in regards to evidence-based practice and basically standardization of care. And probably on that note, now that I've heard you say that you release the protocols to the final year medical students,
yes.
Maybe you can also consider our nursing students in regards to the undergraduate and postgraduate students.
Not a problem. Just drop us an email, emkf@emk Foundation. We'll send you copies.
Okay, sure. Thank you so much.
Not a problem. Thanks, Lucy. Yes. And again, these are not guidelines. At the cover, they don't say emergency care protocols for doctors or for nurses or for clinical officers. It's for the patient. Okay. So at the end of the day, and I'm happy, yes, even the nursing team. And I've found a lot of benefit in having the nurses understand the same things the doctors understand. A lot of it is from a safety net perspective, and I've seen this in our practice, is where maybe you have a doctor who comes in and they are not very conversant on something, or they're ordering something that is not necessarily right, and the nurse will quickly mention and say, let's check the protocols. with the understanding that the nurse knows, yes, on the protocol it says something different, but of course you don't want to fight with it. So can we use the protocols? And that again streamlines and makes sure errors are not being done, and helps, again, it's for the patient, benefit of the patient. All right. So thank you for the feedback, and again, feel free to share as we go on. As you can see, yes, we've shared the protocols countrywide, and I can see, yeah, we have two sets of protocols, and there was a specific reason why we did this. So we have, let me just share this. We have this set, which is the emergency care algorithms, like this is 2021, and this one has a set of up to 44 algorithms. But then we also have the rural setting ones. And again, this one's up to what, 36 algorithms. So the rural settings. Why do we have algorithms for rural settings in our practice? And this, initially, we just used to have one set of algorithms that talked about the evidence-based best practice. But then we realized that when you send these algorithms to Rachuonyo sub-county hospital and you're telling them to get an MRI, then the protocols no longer become useful to them, because they're asking them to do what is potentially not possible anywhere in the nearest county or sub-county. So the emergency care rule algorithms were specifically tailored to provide the best care possible in our resource limited setting. So especially looking at county, sub-county hospitals. So a lot of the recommendations in these specific algorithms have removed, some of the algorithms that have been removed are those where the recommendation goes beyond. I mean, you're saying I cannot tell someone in Turkana, send the patient to the cath lab. What cath lab in Turkana County? But what would be said in the algorithms would be, if you diagnose a patient with chest pain, then you need to consult a physician. Then a physician would then be able to make a best judgment. So it does provide an exit point where you consult someone more senior. The nearest most senior person available, usually a physician or an OB/GYN, depending on the case, specific case, and then this person then would be able to provide the best recommendation or best practice in that setting. So it's not to say that the rural algorithms are inferior to the urban one. And in some situations, we found people use both, but it's just the rural ones provide an exit point that is safe for the patient in a resource limited setting. So it still provides the best care. So majority of the algorithms are actually the same between the rural and urban, because adrenaline is adrenaline, whichever part of the country you're giving it. But there are some specific exit points which the rural one takes for the benefit of the patient in relation to the available to the setting in where the patient find themselves. Yes, but again, both copies are usually freely available for download on the website. So for those who may get the print copies of the rural ones, can still download the full copies for free online. Any comments for the ones who are using if anyone using the rural setting ones? Have you found any gaps, for example, that need to be addressed? We may also be assuming that some things are not available yet they're available. Again, anyone participating, feel free to unmute and just speak. Since we started using them, yes, we've been used countrywide, but also have ended up being used more internationally. So the Comprehensive Advanced Life Support Program is a rural emergency medical education program run from Minnesota in the US that has spread globally, with trainings happening in Kenya and in I know Haiti, and our algorithms became the reference text for this program. And similarly, they are going to be included in the South African. There's a guidelines. It's an app that has guidelines, and they were going to update to upload them there. I know they've done a French translation of the algorithms, but we are still to finalize on that one. So over time, they've gone beyond our borders, and that's why we make them freely accessible, because they're not. We cannot claim that we invented the science. We just curated the evidence into practical algorithms that people can use, and that's the benefit of having them. So they're openly, and I can tell you, when we look at the download data, a lot of people across the world have downloaded them, and our hope is that they are providing them with the um, evidence-based practice that they require, and we'll continue producing them for that benefit. All right, so let's look at the 2021 algorithms and 2021 algorithms and what's new in them. For this specific presentation, I will look at, I use a full one. As you can see, as I mentioned, there are 44, also probably even more than that, plus 5 which ones are not numbered, close to 50 different algorithms. And in terms of the topics have been selected over the years and increased over the years based on what we commonly see in our emergency department. But we are always open to additional topics. So in case there's a specific topic that you struggle with and feel that needs to be included, then you just let us know, and we will be able to create the algorithm for it based on the latest evidence. And maybe at this point, I can ask any specific algorithms that you've wanted to have or never really come across that you'd want included from those who are using the algorithms. Are they comprehensive, or do you think there are a few algorithms that should be added? Okay, the silence, I'm guessing, is they're comprehensive, or people have not. But if we look at all the algorithms available, so there's triage guidelines, there's cardiac arrest, adult cardiac arrest guidelines, there's post-cardiac arrest care, maternal cardiac arrest care. Actually, there's a whole table of contents, which is easier to look at. So as you can see, this is the table of contents, and in terms of how to order them, we've always struggled because of how best to place them for easy reference. But a few tricks on the soft copy. Maybe I can actually just show you how the soft copy works. So the soft copy always has a navigation panel, which is the bookmark pages. So if you want to go to post-cardiac arrest care, I can click that. I can go to any of them as I feel like, which makes it for easier navigation through the algorithms. And also, if you want, you can also just click on the specific, like now to go here, I can click on that until it take me there. So they're as digitally updated as possible. So I want to check on sepsis, septic shock. I just click sepsis, septic shock, and it'll give me that. Or I want to check on epistaxis. I just click epistaxis, it shows up. But also you can navigate through the table, the bookmarks panel on the side. Similarly, so you have all these algorithms available. Other feature that's available is we always recommend that you use MD-Calc with this. So you'll find that at the beginning. You should all have this app on your phone. It has a lot of guidelines, and we recommend you use this app with your guidelines. And again, if you want to download the app, you just click on each of these. If you have an iPhone, you click on that. If you have an Android, you click on that. We also have additional resources, the emergency medicine OneNote, the blog updates. All of this are, you just need to click on the specific link, and it should be able to take you to we're using. So if you're using this on a desktop, especially if you're connected to the internet, then you can easily navigate through different sections. And what we've also done, for example, if I could go to, let me see, Pickflow. Okay, so anywhere you'll see, for example, available in MD Calc, if I click on that part, I should be able to go straight to MD Calc. Let me just share my now new screen. Yes, if you click on it, then you should be able to go to the MD Calc expected peak flow met. So they are linked to the online resources required. They are linked to different parts of the section. So this has been our effort to try to make them as navigable, I guess, as possible. But yes, again, and this is from suggestions from different people. Down the line, probably before the end of this year, if you're lucky, this will all be available in an app from the foundation that will even make it much easier to navigate through. So again, that's what we try and do as much as possible to make it easy for people to use and people to access. I see there's a comment. A couple of things I noticed it would be nice to have algorithms. Vertigo, okay, well noted. Yes, Vertigo algorithm, thank you for that. We will definitely include that in the next. Yes, dizziness is one common presentation in the emergency department. And sometimes people, how to manage a dizzy patient is normally not very clear, so we'll probably try and do something. So normally most of our if you check actually the topics, we label the topics based on what the patient will present with at best. So whether it's hypertension or syncope or seizures, so they're normally based on clinical presentation rather than coming up with a specific diagnosis, because rarely does a patient show up and say, I have DKA, but they will come and say, oh, you may be able to pick up they have hyperglycemia. So from hyperglycemia, then you're able to work them out to get into, oh, they have DKA. Then you go to DKA, and then it takes you down the algorithm that way. So yeah, so for patients, for example, we're talking vertigo, it will be approach to a patient with dizziness. We'll try and build on that algorithm, and then that can be able to support with that. So thank you very much for that feedback. So that's the overview of just what's the digital components of the algorithm. As you can see, services like here, begin number 29. So you click on that, it takes you back there. You go to 30, it takes you back there. So yeah, so anywhere you see like a green, that means it's a link to something. So septic shock will take you there. So that's an easy way to navigate the algorithms as best as possible. All right, so let's specifically now look at what was updated this year. And the first part of the updates was, of course, there was the American Heart Association or ILCO guidelines. As you all know, the International Liaison Committee on Resuscitation releases guidelines every 5 years. The last update was in 2015. The latest update came in 2020, and of course, the next one will be 2025. So the guidelines that came out didn't really have much in terms of changes as per our algorithms, but a few specific things that affected mainly the rural algorithms. The adult ones do not have any pediatric resuscitation part, but the rural ones have. And of keynote was the increased rate of respiration for patients, for pediatric patients, where the new recommendation is aimed for a rate of 20 to 30 breaths per minute. This would be the ideal rate for infants and children receiving CPR with an advanced air in place or receiving rescue breathing. So previously we used to say 1 breath every 6 seconds, which essentially came up to around 12 breaths per minute. But with this new recommendation, then the recommendation is 1 breath every 2 to 3 seconds. And that will give you, that's what we've updated in the role settings algorithm. So if you look at the rural settings, so rural settings is very special because they have both adult and pediatric cardiac arrest algorithm. The pediatric one is not available in the full one, so there are actually some benefits in the rural one that are not particularly there. And what we've done is at the bottom here, I'll just zoom in. Yeah, so as you can see, at the bottom, so we've updated this to say if intubated provided continuous compressions, give birth every 2 to 3 seconds, compared to one birth every 6 seconds that was there in the previous algorithms. So that was one of the major updates in the algorithms. In the rest of this, in this year, the rest of it has actually been the same. But a couple of other things, of course, back while mass ventilation has always been promoted more than using advanced airways in resuscitation. And right now, the drive is not to intubate patients. And if you're going to put anything down, then you should be using a supraglottic device. Issues of cricoid pressure. This one is not new. I think it was outdated very many years ago. We no longer do cricoid pressure because it doesn't reduce the risk of regurgitation during bivalve mass ventilation and may impede intubation success. So cricoid pressure has been thrown out for a while. So only the first part, the 20-30 breaths per minute, is new. The rest of it is evidence that has existed even beyond before the current update. Any comments, questions? Again, this is where you can ask questions and we can provide some answers for clarity. Any questions, comments?
Yes, sorry, Dr. Ushia, I just wanted to ask if there is an age limit for this new breathing rate?
They've just put it for both infants and children. Children, according to HA, is everyone who was before puberty is what we're classifying. So both infants and pediatrics, the rate is 20 to 30 breaths per minute. This is when you're using an advanced airway or you're placing the patient, you're doing rescue breathing for the patient, where the patient has a pulse, but you're just supporting the breath rate, yes.
Right, and just to clarify, Doc, so the 30 to 2 for one rescuer and 15 to 2 for two rescuers is still the recommendation?
Yes, that is still there. The only difference is now the extra ventilation. If when you, let's say you're doing your CPR and you put in an advanced airway, before we used to say just one breath every 6 seconds. Now with that change is now one breath every 2 to 3 seconds.
Right, thank you.
Yes, but the 30 to 2, 15 to 2 still remain the same. All right, any other questions or comments? So yeah, 5 years later, this evidence in resuscitation hasn't really changed much. Frederick, you have a question, go ahead.
And just a comment.
Yes.
I think there's also insistence on using a cuffed endotracheal tube, contrary to previously.
The cuffed tube, yes.
Yes.
So on what Fred is saying, previously there used to be more about you can use an uncuffed or you can use a cuff sometimes. But yes, the evidence behind the cuff tube is to prevent dislodgement and of course provides better seal. And I don't know, Fred, would you know if this is something that even beyond resuscitation, is it something, I didn't dig too deeply, is it something that is recommended mainly for pediatrics that we use cuff tubes than uncuffed tubes?
Yeah, currently it is a recommendation, and I think even ventilating pediatrics with the uncuffed tube is usually poses a challenge with getting the pressures. The ventilators keep alarming, but the uptake still, I think it may take a bit of time because most of the tubes that we find around are uncuffed. Pediatric tubes most of them are uncuffed, so I think the uptake is a bit slow.
It's one of those things will take some time, but yes, now at least for those who are participating, now you know what the evidence is. Yes, we are moving more towards cuffed tubes in pediatrics versus uncuffed tubes, and yes, that was also added as a recommendation in the 2021 in the 2020 AHA algorithms, and that's this one. Yes, cuff tubes decrease the need for endotracheal tube changes. That's important also. All right, good. Any other comments on this? On resuscitation. So resuscitation algorithms have remained pretty much the same for quite a number of years now. We've not really moved beyond what was initially there. And the rates and everything remain the same. The only change is the pediatrics. Yes, so yeah, we have 5 more years of the same. Yes, okay. All right. Unless any other comments, then we can move on to the next one. Okay, no comments, I guess. All right, so the next one is resuscitation of the maternal cardiac arrest. So if we look at, we have the maternal cardiac arrest algorithm. Let me just get there, maternal cardiac arrest. So this is the maternal cardiac arrest algorithm, which is normally very tailored, especially needing to yeah, even the baby is crying. Okay, let me just the maternal cardiac arrest algorithm. Let me do some muting. Just find out who is. Okay. Yeah, that should stop that. Thanks. All right. So the maternal cardiac arrest algorithm targets. This is where mother potentially collapses during delivery or around before delivery, and there are specific changes that needs to be adapted to the resuscitation, which are detailed again. All these have been existed before, but this last box is what changed, this potential etiology for maternal cardiac arrest. So it didn't necessarily change per se, but more or less adapted. So before we used to have BOCHOPS, okay? So BOCHOPS was a mnemonic of maternal cardiac arrest. So bleeding, embolism, anesthetic complications, uterine atony, cardiac disease, hypertension, and then your H's and T's, and then placenta abruptio previa, then sepsis. But because we've always worked with A, B, C, D, E, so I think down the line people have finally just said, okay, let's just go back to A, B, C, D, E. So they've fitted the same causes of maternal cardiac arrest into an A, B, C, D, E format that's more familiar with emergency care practice. So anesthetic complications is this one. So bleeding is still the same. So bleeding includes, of course, DIC, uterine atony, placenta abruptio previa. So issues of cardiac disease, which was still there before, MI ischemia, aortic dissection, cardiomyopathy, drugs. So any drugs the mother may have been receiving or may have been put on prior to delivery or during monitoring of delivery, then embolism, which was just from before, coronary pulmonary amniotic, sepsis, which is not fever, which is sepsis, has been brought in, and then G is general non-obstetric cause of cardiac arrest, which is essentially your H's and T's from before, and then you have your hypertension, which is your preeclampsia. So it's not really changed the causes of maternal cardiac arrest. They've just rearranged them into the familiar ABCDE format, but essentially the complications are all the same. So that's the other change that has showed up in the 2020 algorithms, 2020 guidelines, but it's not really a change. It's more of just a rearrangement of the alphabet to something we are all familiar with. All right, and of course, you should be able to go through this as you're trying to look for reversible causes of cardiac arrest in your patient. All right, good. Any questions before we move to anaphylaxis? So another important guideline that came out last year was the 2020 practice update on management of anaphylaxis by the immunology, allergy and clinical immunology group. So this was quite a big document that looked at all the evidence around and looking at specifically who needs to be what's the best evidence-based practice for anaphylaxis. So if we look at it, this is our anaphylaxis algorithm. So that's a new one. So we were able to update this based on that. So in terms of diagnosis and everything else, that has remained the same. and how to come up with a diagnosis of anaphylaxis. A common thing I always see is many people confuse an allergic reaction with anaphylaxis. These are two different things, and actually that's why the comment here. Patients with simple allergic reactions who do not meet criteria for anaphylaxis may be managed similarly without the use of adrenaline. Okay, but so for the definition of anaphylaxis, you must meet any one of the following three criteria. So acute onset mucocutaneous signs, which is your hives and your itching, and one of the following: so respiratory compromise, hypotension, or hypotonia. Or one other criteria would be rapid onset of two of the following after exposure to a likely allergen. That's mucocutaneous signs, respiratory compromise, hypotension, persistent GI symptoms, diarrhea, vomiting, and the likes. But just hypotension on its own is a diagnostic criteria for anaphylaxis, and especially now, a lot of you are seeing some reactions, especially where you're working with vaccination centers. But I haven't seen any overt anaphylaxis in the vaccines, just some basic allergic reactions. And yes, so people need to differentiate what is anaphylaxis versus what is just a simple allergic reaction, because the two have potentially similar management, but of course, one definitely needs adrenaline. But interesting enough, though, while this statement stands here, a lot of the things that we used to give for anaphylaxis actually do not have any evidence. So antihistamines and steroids were out. No more antihistamines, no more steroids in management of anaphylaxis. You can give them for the itchiness, but you cannot give them to say you're managing anaphylaxis. So there's no really clear benefit in prevention of biphasic reactions or any benefit at all in giving antihistamines and steroids. Apart from for antihistamines, yes, for the itching, yes, you can. Remember the previous algorithms, the 2019 algorithms used to give a H1 blocker and a H2 blocker and steroids, but a lot of the evidence, and again, this was targeting biphasic reactions. So all of that evidence has been thrown out. There's no real evidence. And yeah, so you may give some antihistamines to prevent the symptoms such as itching, but if your patient is not itching, then the antihistamines are out and the steroids are out purely because there's lack of evidence. And that's from this paper. It's quite an interesting paper to look at. So with that change, then yes, we've adapted the same to our algorithms. And so the key parts of our management now is mainly, of course, please, the first thing in the management of anaphylaxis is stop what's causing the anaphylaxis. So if your patient was getting some, of course, if it's an IM injection, you can't suck it out. But if it was a drip that was ongoing, or if it's something like a bead, please make sure you stop. You remove the allergen first before continuing, and then we have your adrenaline dosages, which is simply put, this is the 1 in 1,000, which is not what you normally commonly get. Of course, you're giving it in the anterolateral thigh. And so for adult children, over 12 is 0.5 ml, 6 to 12 is 0.3 ml. The child under 6 is 0.15 ml. The best to use this is you can use your insulin syringes to draw some of these very tiny amounts of drug, but you may need to give with a bigger with a syringe that will go into your thigh muscle better. Looking down at so fluids, and more fluids remain the stay for anaphylaxis. So you need to give as much fluids as possible, and you keep giving fluids as large amounts may be required to get your patient to stabilize, especially where there's hypovolemia. And of course, adrenaline infusion. Okay. So the other question that had been a discussion about anaphylaxis was who gets admitted, who gets home. So current evidence says most patients ideally send them home within after 6 hours of observation in the ED, though even that doesn't really have that great evidence. But what we've included now is a list of who needs to be admitted, and again, that's from this paper. So looking at indications for 24-hour admission, These are patients who there was a delay in the giving of adrenaline, patients who had wheezing and respiratory distress as part of the anaphylactic reaction, patients who've had biphasic reactions. A biphasic reaction essentially is a patient who has anaphylaxis, and then you treat them, they get better, then a couple of hours later, then they have a second anaphylactic reaction. So those are patients who've had similar like that should be admitted. Patients with cardiovascular disease, patients who have a possibility of continuing absorption of the allergen. So this is a situation where you give someone an IM injection and they present with anaphylaxis. So as long as the IM drug is in there, then they will get reactions. So in the specific kind space now, if you give someone the vaccine and they get an anaphylactic, not an allergic reaction, an anaphylactic reaction, they should be admitted at least for 24 hours. Of course, if there's poor access to emergency care, which is pretty much sometimes the whole country, but yes, presentation in the evening or at night, again, should be admitted. And then severe reactions with slow onset caused by idiopathic anaphylaxis, where we actually don't know what exactly is causing the anaphylaxis. So all these groups of patients need to be admitted for at least 24 hours to make sure that they are not really getting biphasic reactions. That would be the main indication for admission. So antihistamines are out, steroids are out, and these are the people who need to be admitted for 24 hours. Any questions or comments on this?
Yes, Doc. I just wanted to ask if the adrenaline infusion can go in a peripheral line. Is that safe?
Yes. So the management, so let me just put this. So the first thing, of course, is not an IV. Remember, the first part is not an IV injection of adrenaline. It's actually an IM injection into the anterolateral thigh. And you repeat this every 5 minutes if no improvement. The every 5 minutes recommendation is because the half-life of adrenaline is actually 5 minutes. Yes, 3 to 5 minutes. So that's why you repeat it. Now, once you get your IV access, then you can give adrenaline infusion only if unresponsive to IM adrenaline and fluid. So it's like a last resort. And yes, there's also evidence that has proven you can give any inotrope via a good peripheral line. Of course, not a small, tiny blue line in the middle of nowhere. So a good green, pink, I don't know what the gauges are, but the line, especially in the antecubital fossa, is safe enough for just a couple of hours, so not for a couple of days, okay? Ideally, it's a stopgap measure as you prepare to insert a central line. So do not delay initiation of IV inotropes because you don't have a central line. You start the IV inotropes and you have at 4 to 6 hours, beyond which then you should have had a central line placed in to give the IV inotropes. So yes, you can give IV inotropes a good peripheral line, preferably a large bore antecubital fossa, or yes, a large bore IV access line. Some people have huge veins, but yes, do not give them for more than 4 to 6 hours peripherally. Good. Any other question? All right, great. So that's anaphylaxis, also quite a new change in 2020. So the next thing we updated, and this has been, I think 2019, 2019 I think is the first time we put, or 2018, the transcutaneous, I see a comment, Trufosa, did the dose of IM adrenaline change? This actually changed not last year. This changed in 2019. The dose didn't really change, but actually those changed in 2019. The 2020 algorithms. I'm not very sure where. All right, so there's a couple of comments here. Yes, the 2020 algorithms changed the dosages, and the recommended dosages now were slightly higher for the adults. So initially it used to be 0.3 milligrams, just 0.3 ml for everyone, but then there was an update on this last year, and this changed to the recommended. So 0.5 IM for the adult, and child over 12, 6 to 12.3, and under 6, you give 0.15 ml. Yes. All right. Tim, you want to comment? I see you on your comment on the chat. You want to unmute and comment? You're welcome.
Can you hear me now?
Yeah.
Okay. Going back to the anaphylaxis thing, just one of the things that we've noticed in my practice in the US specifically is we do use the H2, H1 and steroids, though. The key thing though is make sure that you are giving epinephrine. And I think that's one of the take home that Dr. Bucheri, you were mentioning, is that you really need to give that epinephrine. If you're concerned about anaphylaxis, the epinephrine is a life-saving thing. These things are not, say, providing life-saving treatments. They will help with the biphasic reaction and the down the line problems that you may have with anaphylaxis, but definitely epinephrine is the main thing I think that we're trying to get with the anaphylaxis treatment.
Yes.
So, and when I say epinephrine, I mean adrenaline. I apologize.
Yes, no problem. Thanks, Tim. Yes, adrenaline. Yes, that should remains a mainstay of anaphylaxis. So patient comes in, the first thing you should be pushing is adrenaline, and then fluids and more adrenaline. So yes, all the other things, as I said, may not necessarily be beneficial for a biphasic reaction, but adrenaline, more adrenaline. All right. Good, thanks, Tim. Any other comments from anyone? All right, so the other part that we updated was, and we will work on making some of these videos, is how bradycardia, not bradycardia per se, but the transcutaneous pacing, okay? So the transcutaneous pacing algorithm procedure is never really documented that clearly in many places. So we tried as much as possible to document. So initially we used to just have this part until someone asking for the slides after. We're happy to share them. The whole presentation will actually be available on the talk side. I will share where you can get that. Yes, so on the transcutaneous pacing, so this part was there in terms of what steps to follow to do transcutaneous pacing, and we just watched a video about that just now. But what and also troubleshooting. So we added a second section because we realized people don't know how to transfer patient from one transcutaneous pacer to another. Again, you will find this in the complete algorithms. This is not in the rural setting as algorithms. For again, not many areas have these devices, and this is because we get patients being started on transcutaneous pacing in one facility or in one department, and they need to be transferred to another department. So what we did is put in the steps on how to transfer a patient from one pacing machine to another pacing machine. And again, key thing, of course, making sure that, remember, the reason you started pacing the patient in the first place, you can find that in the bradycardia algorithm, is a patient who is hemodynamically unstable. Let me see if I can zoom in here. So any signs of instability, which is hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, features of heart failure. If your patient meets this criteria, then ideally you should be coming down the bradycardia algorithm, and you have the options of give atropine. If atropine is ineffective, then you can either pace the patient, give adrenaline, or give dopamine IV. But most of the people are actually using adrenaline. So the transcutaneous procedure, we just updated it now to include handing over pacing. And maybe since we can quickly watch this video on how to pace, it's not the how to hand over pacing. We are looking to develop some videos based on the algorithms to also provide better understanding of some of the algorithms. So one of the things that will be next year will be some of these algorithms will actually have videos in them. So yes, that is one of the plans. But we can quickly watch this video about transcutaneous pacing. I just need to make sure.
Introduction to Transcutaneous Pacing by Dr. Unjai Mazwi.
Hello, my name is Unjai Mazwi. I'm a clinical fellow here at Children's Hospital Boston, and I'm going to speak to you about transcutaneous pacing. Transcutaneous pacing is something that's used relatively uncommonly in pediatrics. And so before presenting this, I want to say, first of all, that you might have to adapt some of the methods and some of the equipment to what you have present in your environment. And then secondly, that transcutaneous pacing is not the first clinical method that should be attempted in the stabilization of patients with bradycardia. We are first going to discuss the physiology of transcutaneous pacing, how it's done. Once we've discussed that, we'll talk about the indications for transcutaneous pacing. We'll move on to look at some of the equipment available in hospitals that is used to transcutaneously pace people. And then finally, we will simulate transcutaneously pacing a patient.
Introduction.
The physiology of transcutaneous pacing is that you are using direct current to deliver an electrical charge to the myocardium in an attempt to depolarize enough of the ventricular myocardium to initiate a systolic contraction. Now, the amount of energy that is experienced by the cells of the ventricular myocardium is a function of two variables. The first is how much charge you deliver. The higher the charge, the more likely you are to depolarize the ventricular myocardium once you've crossed that threshold level. And the second variable is the time for which that charge is delivered. The longer you deliver the charge for, the more likely it is to cause depolarization. Transcutaneous pacing makes use of these two in that when we transcutaneously pace, we have a very long time during which the charge is delivered. We call that the pulse width. The pulse width for machines that allow you to transcutaneously pace is about 20 to 40 milliseconds. And the reason that that adjustment is being made is that using a longer time of delivery of energy allows you to deliver a smaller charge with each pacing interval to try to capture the myocardium. The goal is that you are going to either replace or augment the native electrical activity of the ventricle and sustain the circulation by means of pads on the patient's chest. I want to emphasize that the muscle that we are trying to capture when we transcutaneously pace is the ventricular muscle. According to the PALS algorithm, in a bradycardic patient that is symptomatically bradycardic, our initial intervention is CPR and the judicious use of epinephrine and atropine as appropriate based upon what you think the etiology of the bradyarrhythmia is. Transcutaneous pacing should not be your first intervention for bradyarrhythmia in pediatrics.
Equipment.
I'd now like to orient you to some of the equipment that we use when we transcutaneously pace patients. A lot of the functionality comes from the actual box, which interacts with the patient by means of pads or paddles. The pads or paddles are no different from the pads or paddles that are used when we defibrillate or cardiovert patients.
For an adult-sized patient, place the pads over the mid-sternum at the base of the heart and the mid-axillary line over the apex of the heart. If you have a pediatric-sized patient and/or the pads come into contact with each other when placing both pads anteriorly, you should use the anterior-posterior pad placement, where one pad is placed anteriorly in the mid-sternal position and the other pad is placed posteriorly in the interscapular position. Please note that this anterior-posterior placement may lead to ineffective pacing.
During our simulation, I'll leave the pads in front of the patient over the approximate area of the right ventricular apex and the second pad in the anterior axillary line where the approximate posterior base of the left ventricle is. Pacing will allow electrical energy to pass between our anode and our cathode through the mass of ventricular myocardium, which should intervene between your two pads. There are two sizes of pads. There are pediatric pads, which are approximately this size, and adult pads, which as you can see are much larger. The cutoff in deciding when to use pediatric versus adult pads is 10 kilograms. Patients who are 10 kilograms or less, you should use pediatric pads for. Patients that are 10 kilograms or more, you should use adult pads for. The reason that I am emphasizing the use of pads over the use of paddles for this indication is that pads create a much better contact with the skin surface. And that is because they have this large, sticky surface which conforms to the patient's chest wall or back and maintains a stable contact. Paddles, which have a hard surface and also come in two sizes, are much less likely to maintain a stable connection with the patient's chest and are therefore much more likely to lose capture during the process of pacing. Paddles also require that someone stand by the bedside and maintain the paddle contact with the patient, which consumes medical personnel that might be better spent in doing other things to help stabilize the patient or move them to a safer location where more definitive therapy can be decided upon. Looking now at our box, the functions that we're going to use when we pace patients are built into the normal functionality of these units and are typically clearly marked. Virtually all devices that allow you to pace will have a certain amount of basic functionality. So we have a dial on this machine that allows us to select pacer. Once we've selected pacer, there are typically 3 other buttons that we are then able to use to specifically decide upon what we want to use to help pace a patient. The first is the pacer output. When we press the pacer output, it gives us the amplitude or the size of the charge that is to be delivered to the myocardium. Most pacing units will default to an adult setting, which is about 40 milliamps. It's reasonable to start with either 20 or 40 milliamps in pediatrics and then adjust from there as is necessary. To adjust that, on this machine, there are arrow keys that allow you to increase the amount of delivered electrical energy or decrease it as may be appropriate. On this machine next to the pacer output button, there's a pacer rate button. When that's highlighted, most machines will default to a standard adult pacing rate of about 70 beats per minute. That can be adjusted also by means of the same arrow keys that we just discussed to a rate that is more appropriate for pediatrics, such as 100 or 120, depending on the patient's age. When you have selected settings, the final button is the start pacing button. When that is pressed, you deliver the current that you dialed in as many times a minute as you dialed in on that second button to the myocardium.
To set up demand ventricular pacing, first synchronize the pacemaker box with the ECG monitor on the patient. This can be done by connecting a sync cable from the ECG monitor to the pacemaker. This will allow the pacemaker to see the patient's QRS complex. This will allow the pacemaker to synchronize its pacing to the patient's intrinsic heartbeat, thus preventing it from blindly pacing into a more vulnerable period of the heart's repolarization and causing ventricular arrhythmias.
So this is equipment that is in your hospital and that I recommend that you try to become familiar with for that rare clinical circumstance in which this might be necessary.
Preparation for procedure.
Now let's talk for a minute about actually selecting the current. What you are trying to do is you're trying to use as much current as is necessary to capture the ventricular myocardium, but not any more than you need to. And that's because the application of electrical charge to the living cells of the ventricular myocardium ultimately results in ventricular injury. The way that you decide what current to leave a patient paced at is once you've switched on your machine, so we'll switch on our machine, and you have selected pacing, which I have just done, you choose the output that is necessary to capture the ventricle by continuing to go up on your current or down on your current until you are able to document capture. And by capture, I mean that the electrical charge delivered is sufficient to depolarize enough of the ventricular myocardium to cause a sustained ventricular contraction. There are two ways of assessing whether or not that has happened. One, a safer way and a more intuitive way of assessing whether or not you have captured the myocardium with the amount of energy that you have delivered is by feeling for the patient's pulse. Unlike cardioversion and defibrillation, you can safely continue to assess your patient while you transcutaneously pace. And by continuing to assess and support your patient, what I mean is you can feel for a pulse, you can continue chest compressions, and you can safely administer medications without risk of harm to personnel. And the second is by looking at the little pacing spikes on the QRS complex, either on your machine or up on your monitor, and making sure that there's evidence of ventricular systole following the application of that charge. And typically, that'll appear as a wide QRS complex. We talked earlier about how you can select a current and you can select a time for which that current is delivered. With a fairly basic machine like this, you are not able to select the pulse width or the time. That's automatically chosen for you, and that's either going to be the 20 or 40 milliseconds that we discussed earlier. What you're able to select then is the delivered charge, how many times a minute you deliver it, and start pacing. Once you have decided at what current you have captured the myocardium, and that's that current that either shows up as a wide QRS complex on your monitor, which I will demonstrate in a minute, or that current that is associated with the presence of a central pulse, so that's a carotid pulse or a femoral pulse or brachial pulse, you continue to dial that current down until you lose capture. And the loss of capture is documented either as the loss of evidence of a QRS complex after your pacing spike on your monitor, or the loss of a pulse at the bedside. Once you have lost capture, that's considered your threshold level. The last current that you delivered that captured the myocardium is your threshold level. Typically, to stably pace a patient, you will then select a current that's 10 milliamps higher than that level at which you lost capture. So assuming that we started at 40 milliamps, and we had good capture, and we continued to dial down, and we lost capture at 20 milliamps, a safe place to leave this patient paced would be 30 milliamps, or 10 points higher than our loss of capture.
Case demonstration.
I'm now going to demonstrate transcutaneous pacing in a patient. This is a 7-kilogram infant who has presented to our ER and is currently in a hemodynamically stable sinus rhythm with an acceptable blood pressure of 84/39. Now, I want to emphasize again that the first intervention for bradycardia is, according to the PALS algorithm, the initiation of CPR, if you believe that this is a symptomatic bradycardia, as would be indicated by evidence clinically of poor perfusion, such as weak pulses, prolonged cap refill time, evidence of decompensated shock, such as a change in the neurological status, and hypotension when you cycle your blood pressure cuff. After you have initiated CPR and administered effective medications, if medical management is unsuccessful, transcutaneous pacing is an additional temporary option until you figure out a more stable means of capturing the myocardium and supporting the patient's circulation. We now have a patient with an unstable sinus bradycardia. It's hemodynamically unstable and it has failed medical management. So we're going to try to transcutaneously pace this patient. We start by switching on our machine and selecting the pacer function. You then select the rate that you want. This is a 7-kilogram infant, so I'm going to try to pace this baby at about 110 beats a minute. And then we start with a standard output of 40 milliamps, and we hit start pacing. Currently, we are not pacing. So what I'm going to do, you can see our pacing spikes, which are not followed by QRS complexes. I'm going to keep augmenting our current until we can see a QRS complex following our spikes. And there we go at about 60 milliamps. Each pacing spike is intermittently followed. We still haven't got full capture. At 65, I appear to have full capture. The little white lines that you are seeing are a pacing spike, and you can see a peaked QRS complex with that upright R wave following the complex. Now what I'm going to do, we've established that we have captured the myocardium at a rate of 65. I'm going to reassess our patient's hemodynamics. We're now pacing at a rate of about 109. I'm going to feel for a central pulse, which I'm still having trouble feeling. And we're going to reassess our blood pressure by cycling our blood pressure cuff. And there we go. Now I have a good central pulse. Patient is warming up. The cap refill has improved, and we have a perfusing blood pressure. We've established now that we can capture the myocardium at this current. What I would like to do now that we have stabilized this patient and we think that we have a good capture of that myocardium is figure out at what setting we're going to leave the patient while we figure out a more stable way to support them in the intermediate to long term. That involves going back down on my current to figure out where I lose capture. So I was only 5 millivolts above where I lose capture. This is now 6 milliamps, 60 milliamps rather, and at 65 milliamps, we start to capture the myocardium. As per the rule that we discussed, a safe place to leave a patient is 10 milliamps above your threshold. So if 65 is approximately our threshold, I'm going to go up on our pacer output to 75 milliamps, leave the patient at this heart rate of 110, and then reassess my perfusion. We have an improvement in our systolic blood pressure. We have good, strong central pulses, and we have the consistent appearance of a QRS complex after our white pacing spike. And that concludes our segment.
Please help us improve the content by providing us with some feedback.
Okay, so I know that was for pediatrics, but the same steps pretty much apply for adults. Any questions on the transcutaneous pacing? So what you will see then additional to the algorithms is now once you have that patient paced and then you need to transfer them to another facility or another department, how do you hand over pacing to that other side? All right, any questions on this? Okay. So the next thing that was new to these algorithms, let me just share this. So the next thing that was new is cardioversion. Again, something we assume many people know until we realize many people don't know how to cardiovert a patient. And what we added, so pacing used to be there before. Now what we've added is a synchronized cardioversion procedure that goes step by step on how to cardiovert a patient, and goes step by step, and also what to do in terms of troubleshooting for the patient. So it goes very provides as much guideline as possible on this. There's a question. Yes, Frederick, thank you for that part. I'd actually forgotten about that one. Yes, thank you, Fred, for reminding me. Yes, we did update. So another change in the AHA guidelines was the dosage for atropine. Previous dose used to be 0.5 milligrams. This has been updated now to 1 milligram in the new guidelines. Thank you. That's something I should forgot in the 2020 guidelines. And we did update on our own algorithms, yes. So the first atropine dose used to be 0.5 milligrams. That has now been updated to 1 milligram bolus, not 0.5 milligram bolus. So thank you very much for that update, Fred. Another comment is issues of demand versus fixed mode pacing versus demand mode pacing. Fixed mode pacing, essentially the machine paces the patient regardless of what the patient's own intrinsic cardiac activity is. So if you set fixed mode pacing at, let's say, 70 beats per minute and the patient's heartbeat goes to 80, the machine will still keep pacing the patient for at least for 70 beats per minute. In demand mode pacing, if your patient's heart rate goes above what you set, so let's say you set 70 beats per minute, and your patient's heart rate goes to 80 beats per minute, then the machine normally will go into what we call a standby mode. Now, when you're in the emergency setting, we normally will promote use of fixed mode pacing for various reasons. Typically because your patient is normally temporarily in the emergency department, they'll have to be transferred somewhere, and you may not be able to continuously monitor the patient. And then you don't want your machine going into standby mode because you've hit a few corners and bumps trying to transport the patient, or your patient has been moving up and down, for example. But if your patient is in a stable ICU setting, they're not really going anywhere, then they should be on more demand mode. So simply put, if your patient is not going anywhere and they are comfortable, put them on demand mode. If your patient is in a temporary situation and they're moving around or being moved from department to department, then you should put them on fixed mode, okay, where you're not able to keep monitoring the screen. You do, when you're transferring, that ability to switch between demand mode and fixed mode is what actually allows you then to transfer a patient from one transcutaneous pacer to another, because you just need to keep one on demand mode and then set the patient on another monitor at a higher rate, and the first monitor will go on standby mode. So you can read all that in the transfer of transcutaneous pacing algorithm. Thank you, guys, for the update on that one. Yes. So as I mentioned, the other thing that we did put in was cardioversion, and we can quickly watch a video on how to cardiovert a patient.
With synchronized cardioversion, you deliver a shock synchronized to the R wave of the ECG being monitored in wave sector 1. You can monitor and perform synchronized cardioversion through the multifunction electrode pads or external paddles. Or you may choose to monitor the ECG through monitoring electrodes connected to a 3, 5, or 10 lead ECG cable with the energy delivered through the pads or paddles. In this case, we'll assume we have prepared for both monitoring and synchronized cardioversion using the multifunction electrode pads and have a clear signal and large QRS complex. With the therapy knob in the monitor position, press the sync button to activate the sync function. This message appears. Confirm that the sync marker appears with each R wave. Turn the therapy knob to the desired energy level setting. Press the charge button on the MRX. Make sure no one is touching the patient or anything connected to the patient. Press and hold the shock button on the MRX. A shock delivers on the next detected R wave. You can deliver additional synchronized shocks simply by pressing the charge and shock buttons again. Disabling the sync function is as easy as pressing the sync button.
All right, that was quick. Yes, questions on terms of sedation. Someone asking, are we giving sedation? Yes, we do sedate all these patients who are getting electricity given to them. well, apart from the cardiovascular, for the defibrillation one, okay? Here you can see it says consider procedural sedation and analgesia. Similarly, with the transcutaneous pacing, it does say consider procedural sedation and analgesia for both of these groups of patients. Yes, always remember that. It's a painful procedure and you have to titrate your medication. Again, always be cognizant of the blood pressure, because if you're going to give any of these drugs for analgesia, for example, like your midazolam, and this we've put this across the document, always reduce your doses for analgesia, especially your opioids and your sedatives in elderly patients and in critically ill patients, purely because of the blood pressure effect that they have. So we've added that comment in a lot of the discussions in the books. All right. Let's see. There's someone who's typed a very long question. V, I just see the name as V. Feel free to just unmute and ask the question, please. Someone by the name V. Trying to see who that is. Yes. Okay, so the question, just to look at the chat, is with regards to PEDS resuscitation, the emphasis on brachial pulses when checking for pulse to determine chest compressions. Question, most times the brachial pulse is so hard to palpate. Can the femoral pulse be used? And most times it's a respiratory collapse. So at what point can you safely stop compressions and just continue the rescue? So on that question of rescue breaths are normally given to a patient who has a pulse. Just the clarification on that one. Rescue breaths are normally given to patients who have a pulse. If your patient has no pulse, then you should be doing your 15 to 2, 30 to 2 as appropriate. You can, if a patient has no pulse, you must give chest compressions. Yes, and of course, if your heart rate is less than 60 in pediatrics, you always start chest compressions until your heart rate is above 60. Yes. Any other questions or comments on that? Like I said, you can always unmute your mic and comment. Feel free.
Hey, just to clarify, Dr. Chair, the 15 to 2 is only if you do not have a definitive airway in place. If you have if your patient's intubated, you should be able to give the 1 every 6 seconds for the adult patients, 1 every 2 to 3 seconds for the pediatric patient, if you have an intubated patient.
Yes. Yeah. So any patient who has an advanced airway, because the same also applies if you have an LMA or the rest, then yes, you should be able to give the 1 to 2 to 3, 1 breath every 2 to 3 seconds, and continuous CPR. So if your patient has an advanced airway, you are doing continuous chest compressions at a rate of 100 to 120 compressions per minute. So that's, I think that's the main thing on that one. Yes, thanks very much, Tim. Yes, I hope your question has been answered. If not clear, you can still always type the question and we'll be able to see if we can clarify. Yeah, so just a comment, rescue breaths are for people who have a pulse. Yes, rescue breathing is for people who have a pulse. If you do not have a pulse, you need both chest compressions and ventilations. Yes. Okay. All right. What else? Okay. All right, I think we can take, what time is it? We can take a 5 minute, we've been going at it. I know people may want to go quickly dive somewhere. Let's take a 5 minute break to grab a cup of coffee and chat to each other. Then we'll be able to continue. So 10:45 or so we restart, so that we give people a bit of a break from this discussion. Yes, feel free to unmute and talk amongst each other. All right. Any questions? Looking at some of the comments or some of the questions. So, which is the best part to check for a pulse when pacing? I had neck muscles contract. That you can give a false pulse. Yes. And even on the algorithms, we do recommend checking for the femoral pulse, just not to confuse the twitching of the, yes, you can see it says check the femoral pulse to avoid the twitching that normally happens in the neck from the pacing. So that's always the best option. In terms of team, Etomidate is not licensed in the country. Dexmed is in fancy hospitals, the bigger private hospitals. And yeah, so Etomidate, ketamine is available. And yeah, so ketamine is available. So Dexmed is available in bigger facilities, private facilities. Etomidate is not available in the country. Yes. All right. Okay, so let's continue. Let's continue with what hypertension. So I think if there's a group that is very always busy coming up with new guidelines, it's the hypertension people. Every time there's a new one. So the 2020 International Society for Hypertension Global Hypertension Practice Guidelines were released last year, and there are some changes put in. They finally put this in a diagram, which is really good because many people actually don't know how to take a good blood pressure on a patient. So there's a nice picture. We put this also in the algorithm. Interesting part you should always hear at triage is no talking during and between measurements. For those who do triage, you're always asking questions as the blood pressure is being measured, but ideally your patient should not be talking as per the recommendations. Of course, the cuff should be appropriately sized. Patient should be in a quiet room. The cuff must cover, as you can see here, the cuff must cover 75 to 100% of the individual's arm circumference. And then arm should be resting mid arm at the heart level. It should be resting on a table. Of course, you need a validated electronic device. Patient's feet on the floor. Patient should be in a quiet room, comfortable temperature. No smoking, coffee, exercise for 30 minutes, which is never really something you can control. They should have an empty bladder. Again, also not something you can really always control. But yeah, so this just shows you how to accurately take in a blood pressure. And the recommendation here would be take 3 measurements in 1 minute intervals. Use the average of the last 2 measurements. Again, something may not be practical, but I think the emphasis here is always to make sure you do not jump to call someone hypertensive just by measuring one blood pressure, especially if you have not, remember, hypertension treatment is lifelong treatment. So you need to be able to accurately measure their blood pressure so that when you're telling someone they're hypertensive, it's truly that they are hypertensive. So there was a recategorization of blood pressures, normal being 120/80, and then what they called as an elevated blood pressure, which is 120 to 129 and less than 80. And then stage 1 hypertension is 130 to 139 with a diastolic 89. Stage 2 hypertension is 140 or higher, and or 90 or higher. That would be stage 2 hypertension. And of course, hypertensive crisis did categorize as more than 180, 120. So looking at the algorithm that we've updated, so we updated all the things on the algorithm. It's come hypertension algorithm. Yes. So the nice gentleman sitting there with the different cutoffs. So that's totally new. And then they did put in now, we did put the algorithm of the recommendations for the different, so single BP measurement, if it's normal, high normal, or patient hypertensive, which is stage 2, take 2 more readings and what to do with that, what lab tests to order for the patient, And then they have provided guidelines for grade 1 hypertension treatment, grade 2 hypertension treatment, and appropriate lifestyle modifications that these patients should go through. The appropriate drug therapies based on the race, which is not necessarily more of us on the black side most of the time. And then, of course, on monitoring. So all these are available from the guidelines provided, and we've updated the guidelines based on these recommendations and included the appropriate charts on this. So that's a blood pressure update on the algorithms. And then, of course, this is also, there's a section on hypertensive emergencies on our algorithms. If you could just have a look at that. So hypertensive, there's a whole section on hypertensive emergencies algorithm. And again, you can see if your BP is above 180, 120, that's when you're talking about hypertensive emergency. And there are specific recommendations down the line. And this is more of a narrative, but updated was in the form of a table and looks at management for the different hypertensive emergencies, appropriate drug therapies and alternative drug therapies. So, and what your targets should be. So this has been captured in the narrative, looking at the different, so if it's aortic dissection, heart failure, or acute cardiogenic pulmonary edema, your eclampsia patients, stroke patients, ischemic hemorrhagic strokes, being thrombolized or not, encephalopathy patients. So again, this is captured in the narrative and we've updated it based on the guidelines from last year. Another specific update that we added was some specific measures in severe bleeding. Any questions, sorry, on the hypertension? If there are any questions on the new hypertension guidelines? So this keeps changing quite frequently, and that's the importance of always updating your algorithms, because I think we've done so far maybe around 3 updates since we said algorithms on hypertension, because they keep coming out every year, every other year. So always keep up to date, make sure you're using the latest algorithms. So this was a specific chart that we included that I found very handy. So we put it on the trauma section, but essentially captures more than just trauma bleeding. So specific measures in severe bleeding. So it goes way beyond trauma and looks at the different, so you can see the specific measures in severe bleeding. So whether you have head and neck bleeding, so if it's scalp bleeding, staple sutures, pressure dressing, epistaxis, we have a whole epistaxis algorithm. So this is actually well captured in the epistaxis algorithm. And then we don't see a lot of post-tonsillectomy bleeding here. If it's trauma, how to put in a patient with a penetrating trauma in a junctional area and they're bleeding, you can put in a Foley's catheter and inflate the balloon to just stop the bleeding vessel. In terms of putting a pelvic binder or traction split for your pelvic fractures. The right pressure and tourniquets in patients who have arterial limb bleeding, and then in maxillofacial fractures, reducing midface, and then of course rapid sequence intubation, epistaxis, and bed block and collar. Hemoptysis, nebulized tranexamic acid, and then also in hematemesis or GD, varicose, then you consider that, talipressine if available. Intracranial bleeding, this is what was being captured in the hypertensive emergency guidelines. Obstetric bleeding, get a fast if it's first trimester, consider ectopic, so consider cervical shock. In antepartum bleeding, again, you need to get OBGYN involved, and then there's always the whole torn tissue trauma thrombin. It's a good summary about all types of bleeding, and then management. So, for example, obstetric and in pediatric, you have your part rate, your dosages for the different drug therapies, so part red blood cells, platelets. Tranexamic acid. So tranexamic acid is something that essentially is not being used a lot for different groups of patients. They should be getting tranexamic acid. And we've put this as a recommendation in the different algorithms, whether it's epistaxis, whether it's trauma. Trauma has 2 indications for tranexamic acid, which I will just share on the algorithm just now, actually. If we're looking at tranexamic acid for trauma management pathway, so we can, let me just do that. So indications for tranexamic acid is for all trauma patients with risk or at risk of significant bleeding, and then adults within 3 hours of injury with a GCS score of 9 to 12 or 13 to 15 with an intracranial bleed on CT scan. All this then needs to be given tranexamic acid. Similarly, tranexamic acid, but this has been there since CRASH 3, which I think was even before this. And also epistaxis is tranexamic acid, maternal bleeding is tranexamic acid. So these are different indications for tranexamic acid. The dosages are pretty much similar. All right, so that's on that update. So we've included that. This is something that had been left out in the previous algorithm. It had been mentioned, but not really detailed in terms of suicide management. And where things are going, we are going to see a lot of mental health really growing, becoming a common thing in the emergency department. So the safety is a suicide assessment, 5-step evaluation and triage, but it starts off with a suicide homicidal evaluation. There's a whole process, there's a whole algorithm for this. And then you use the decision support tool for secondary screening, and the details of the decision support tool is here. And if your score is 1+ and you use safety, which is now what we've included there, it wasn't there in the previous algorithm. So looking at risk factors, protective factors, and then suicide inquiry, risk level or intervention, and then being able to categorize your patient in terms of high, moderate, and low, and appropriate interventions for each of the groups. Yes, so mental health is something that will commonly present in the emergency department, and it's something that we need to be able to appropriately evaluate the risk level, especially where we have limited resources to admit some of these patients. So you must always be able to do a proper assessment in consultation, of course, with psychiatrists. So this has been something that we've added a lot and has been quite useful. And beyond the safety, there's some brief suicide prevention interventions, and then there's a basic needs suicide hotline that you can always have people call. This is a Kenyan number, yes, that you can actually use to support these patients. All right. So yeah, that's safety, identify risk factors, protective factors, suicide inquiry, risk level intervention, then you document. That's a safety assessment. All right, methanol poisoning was the other update. Again, let me just get back to that. Any questions? Sorry, as I go to, if you have any questions on the suicide algorithm, let me know or just comment. Methanol, a lot of methanol poisoning. It's become not that common. I don't know how many people are seeing methanol poisoning as of late, but what we added to this was the use of available alcohol, because most of you may not be able to get the industrial ethanol, well, okay, not at facility level, but I'm sure you have access to vodka and gin from your local supplier. So yeah, so at least 35% proof alcohol, and it gives you the appropriate dosages for adults, the possibility injures, and then maintenance dose. And yeah, so that component of oral dosing is what we added, where you do not have pure ethanol available from your pharmacist. Yes, the hospital pharmacist, not the other pharmacists. Yes, so make sure that so this was to help you. And yeah, we have a lot of patients. Previously, it used to be quite common, though the numbers I see have reduced. I haven't seen a feature anytime recently, but yes. So if you have a patient with ethanol poisoning, that's how to use vodka to support your patient. This was from looking at, this is a methanol poisoning fasted alert from picked up from online from, I think it was India. And yes, they are giving this how to use some of this alcohol content, and it gives you oral dosaging for the different patient's body kilograms, which is what we've now broken it down to be more helpful on the algorithm. All right, almost finishing off. So the WHO came up with two checklists. There's a trauma emergency checklist and there's a medical emergency checklist. So we kind of looked at this and looked at what we had in our algorithm. So I didn't think we had already included it at the end of the algorithms, the emergency care checklist. So we combined both to come up with this. So it includes both. Oh, sorry. So it includes both medical and trauma checklists. And this is a good checklist when you've assessed your patient and just like making sure you've gone through everything or before you transfer your patient. So it can easily even be used as a transfer guide, making sure you've checked off all the boxes, whether it's a trauma patient or medical patient, and it helps you make sure you've gone through what needs to be done for the critically ill patient. So it's a good guideline or a good checklist for you to just go through before moving the patient anywhere or at the end of your patient assessment to make sure you've captured all the components. And that's why we included it at the end of the checklist. It's again based on the WHO medical and trauma checklist. Okay, so as you can see, before the team leaves the patient's bedside, some things to continue checking and to make sure that are completely done. And then just before the references, this is new. The Pediatric Emergency Reference Guide is in both algorithms. This was a chart from Gertrude's Children's Hospital that we thought was quite useful. Especially our algorithms normally are not pediatric specific, and we thought it would be good for us to just include this chart to support those ones who may come across managing a pediatric patient. So it provides a lot of good information in terms of, let's say, for example, in a patient, based on age group, you're looking at their weight, the pulse rate, rest rate, appropriate, what is ideal systolic blood pressure, diastolic temperature, ET tube size, ET tube depth at the lip, laryngoscope blade size, LMA size, NG tube size, suction catheter size, dosages for adrenaline, again also details on the ET tube, terms of things is how many mLs to inflate. No, sorry, it's adrenaline via ET tube, via IV, for anaphylaxis dosages. Okay, so that's been captured there. And then dosages for things like adrenaline, morphine, fluids, defibrillation, cardioversion. So it's like a comprehensive chart, and we will be updating it as we get more information that we feel relevant to be here. So the idea behind the chart, of course, is to make sure that in case you come across, our algorithms normally are adult targeted, but in case you come across a pediatrics, you should be able to provide similar care using the appropriate dosages and assessments based on this chart. So that was the idea behind this. Okay, good. So almost done. So that was that. Yes, so that's in a nutshell an overview of the updates from the 2021 algorithms. Comments, questions, anything that needs clarification, anything that's not clear, any suggestions, as we're always looking to update the algorithm. So we'll be looking to update the current ones to the 2021 algorithms. And this is normally based on the feedback we get from you on the ground. And of course, as the science also adapts. Questions, comments, suggestions? Okay, you're welcome, Samsung. We don't have a name, but yes, you're welcome. We hope that the algorithms are helpful. But again, the objective for us is to make sure that these algorithms are translating to good patient practice on the ground. It's no use having algorithms that and then no one is using and patients then are not getting appropriate care. So definitely thank you very much for the feedback. Any specific feedback? So app-based version, yes, we are working on the app-based version of the algorithms. We hopefully will release that and the additional videos to be included, additional educational videos. Okay, any other comments, questions? Any yeah. Okay, thank you very much, Lucy. Lucy, please just email us. We'll be able to send you print copies to your students. I think that's useful for us. That's our objective, is to get the print copies to the students. And for those who have to buy the print copies, when you buy a print copy, it helps us donate free ones to the rural facilities. So the encouragement to buy the print copies is to support us donating them to as many facilities as possible. So yeah, just go to the website and buy yourself a print copy. This is quite helpful for us to donate them. Yes, so to buy a print copy, just get them WhatsApp from the website, and then we'll be able to send a print copy to you wherever you are. All right. Available in Swahili. Yes, Ivy. That would be. Yes, I need to speak to some Tanzanians. But I don't know. I always think regionally medicine is taught in English. Am I not accurate? Ivy, since you brought it up, you can comment.
I knew you were not going to spare me. How is everybody? Greetings from Mali. Yeah, so I was just thinking, because you were revising, and maybe for the next one, because if we go to the regions, sometimes, and obviously they're more, like Tanzania, they're more comfortable with Swahili. I mean, something for them to have to read with ease. Well, but if all medicine is taught in English, then, well, who knows?
Anyone from Tanzania, Rwanda? I thought the medicine is taught in English, so that's my hope. Because yeah, it would be interesting to translate it to Swahili, but that will be, yes, quite a task actually.
Yeah. Yes. Okay. Thanks.
All right. Any other comments? Yeah. Routine use of Silox dressings for epistaxis. Maybe Japheth, can you explain to us what Silox dressing? I'm not sure what Silox dressings are. Maybe you can unmute and just explain what a Silox dressing is. Japheth, or does anyone know what a Silox dressing is?
Thanks, Professor. I've seen in some practices that some surgeons would recommend for these Silox dressings. Basically, I think they do have some anticoagulation component in it. So I don't know whether it's routinely used or it was just clarification.
Okay. Let me just share my screen because I've Googled quickly to find out what Silox dressings are. So Silox is a hemostatic gauze. Gauze strip controls moderate severe bleeding. I've not seen the evidence for it in what's this thing called, in epistaxis, but you do use gauze, just plain gauze, in epistaxis. So I feel you should be able to also use this, but I'm not basing this on any evidence I've seen. But I don't think it's readily available, and the field people, I'm sure, are the ones who have Silox dressings. If you're working on the field, they're the ones with these fancy dressings. But yes, it's gauze, and if you look at the algorithm, if you were to look at the epistaxis algorithm, let me just pull that up. Epistaxis.
Doc, can
Yes.
I give a
Yes.
comment from the
Go ahead.
field?
Yes.
So yes, here even here, because we have so much trauma,
Yeah.
the only guys who are using the Xelox gauze is, let's say, those who are getting to the scene of active combat. But even then, when they bring them to us for damage control surgery, it's very difficult to remove this gauze because of those granules. So usually, unless like we're caught in a situation where there's no other option, or the landing zone, we know that there's going to be time lost because it's life of a limb. So we, at the very, very end, we do use that Xelox dressing. But so I wouldn't think that it should be an option for epistaxis.
Yeah, especially if you're saying it's going to be difficult to remove, then it may just cause more harm removing it. Exactly. Yeah, so I think based on field experience, as I said, I don't have any evidence on this, but based on that comment, yes, it does. I probably would not, if it's going to cause harm removing it, then, but again, there's plain gauze soaked in either adrenaline or tranexamic acid, and of course oil with bacitracin ointment works very well. So I think that would be my recommendation on that, based on that feedback. All right, good. Any other comments? Okay, so quickly before stop share, quickly before we end this session, I'm gonna you can use gauze soaked with adrenaline. Yes, you can. That's actually what's in the protocol. You can check the protocols for how to develop that gauze soaked in adrenaline. Since we're in the middle of COVID, I think it's only practical that we maybe just discuss some two evidence-based things in the COVID management. Yeah, so this is not really an opening into a whole COVID discussion. It's just looking at the evidence behind some of the therapies being recommended. And this would be from the two trials that have been conducted, both by the recovery. So in no way is this an opening to a whole discussion of COVID. I'm saying, can you use paraffin soaked gauzes? I think, I'm not sure what the effect the paraffin has, such short of just lubrication, and also preventing, I think the paraffin is more like the bacitracin ointment, preventing buildup of bacteria on the gauze. So, and I know that's what sometimes is available on the ground. Anyone with any evidence around behind the paraffin soaked gauzes? Yeah, okay. Some hemostatic dressings are available, are absorbable. Yes. So it's it's nice to be using fancy, but if plain gauze works just as well, and most of the time actually you don't even get to the gauze part. So my recommendation would be bacitracin soaked ointment with gauze and gauze that is soaked in bacitracin ointment, and then plus adrenaline or tranexamic acid as B. That works most of the time. In terms of so this, let me just share this. For your COVID-19 patients, the recovery trial, use of steroids. So for patients who are on oxygen, there was the steroids in COVID-19 patients, systematic review meta-analysis and outcomes. And this looked at the different studies that I've been looking at, and there is definitely a benefit for giving dexamethasone and steroids in patients who are on oxygen. Okay, that's where most of the evidence has been shown. Patients on oxygen should be getting steroids, and this should be given in the emergency department, especially since sometimes you don't know where the patient is going after. So there is good evidence for steroids in COVID-19 patients who need oxygen. The second recommendation that's there so far is the use of tocilizumab. So this again was this for the same group that the recovery trial that looked at steroids, also looked at tocilizumab, and this again is for specific patients. So it's patients who are hypoxic on oxygen or requiring oxygen therapy with elevated CRP more than 75, okay, are the ones included, given at a dose of 400 milligrams initially to 800 depending on weight, and a second dose given 12 to 24 hours later if the patient's condition had not improved. And based on this also, again, they also found good evidence in terms of outcomes. The outcomes that were specifically being looked at was clear mortality benefit. There was a mortality benefit in those receiving steroids. So it's tocilizumab plus steroids, not patients allocated to tocilizumab are more likely to be discharged from hospital alive at 28 days with good confidence at a good rate. This is patients on tocilizumab plus steroids. And then for those not receiving ventilation at baseline, patients allocated to tocilizumab were less likely to need mechanical ventilation. Again, also some good evidence behind that. So far, that's the evidence that's there for COVID is the two drugs. No good evidence for convalescent plasma, no good evidence for hydroxychloroquine. I don't have those ones here. But yeah, so far, a year later, those are the two main forms of therapy that have been shown to have some benefit. As I say, this is just a quick update. Any comments on this or any questions? Okay. Well, if there are no questions, no comments, I'd like to say thank you all for joining us for this month's presentation. We'll have another one at the end of next month. We'll normally release the topic somewhere mid-month once you've confirmed what the discussion will be like. But if you have any suggestions for topics, any suggestions for what you'd want us to discuss in depth, please feel free to just drop us an email at emkf@emkfoundation.org. And also more than happy, please do give us your feedback. In your feedback, you can also add comments about so I've put in the chat there our feedback form. Use that to provide us feedback. Let us know what you think. Let us know what you want us to discuss. The idea behind the monthly talks is for us to be having discussions and not me to be speaking continuously. Yes, but very much welcome your feedback on how best you can make these sessions more engaging and more productive for you. All right. So use the feedback form to give us your feedback. I'll put the link to the feedback form on the chat, so you can use that to give us your feedback. Really appreciate it. Otherwise, do enjoy yourselves, keep safe, and those in the zones and out of zones, take care of yourselves. We'll see you next month. Thank you very much. Goodbye.
Bye, and thank you.
Bye.
Bye, Doc. Thank you. Stay safe.
You too. Bye.